Hello, everyone. Thank you for inviting me. I'm Claudio Sandroni from the Catholic University School of Medicine, Policlinico Universitario Gemelli in Rome, Italy. I have no conflicts of interest to declare. Mortality after cardiac arrest is high. These are data from the Italian Cardiac Arrest Registry, and they show that 2/3 of patients who are resuscitated from cardiac arrest don't achieve ROSC, and among those who achieve, 2/3 die before hospital discharge. This high mortality is biphasic, both in terms of causes and in terms of incidence. During the first 3 days after cardiac arrest, there is a high incidence of deaths due to cardiovascular causes in gray in the graph, and then there is a long plateau of neurological deaths. Let's focus on the first one. Post-cardiac arrest cardiovascular dysfunction has too many components. The first one is the reduced cardiac output due to ongoing myocardial ischemia. Indeed, myocardial ischemia is the main cause of out-of-hospital cardiac arrest. These are data from the French registry, including almost 1,500 out-of-hospital cardiac arrests, and they show that more than 60% of these arrests are from cardiac cause, and among them, the vast majority is due to an ischemia. Actually, ischemia accounts for more than half of these arrests. So it may make sense to triage patients for reperfusion therapies based on their post-ROSC ECG. And it's pretty straightforward when there is NST-MI pattern, which includes NST segment elevation or nuance at the left bundle branch block. More than 80% of these patients have an acute lesion on coronary angiography, and there is wide consensus that emergent cardiac catheterization is indicated. Unfortunately, however, things are less straightforward when there is an N-STEMI pattern. With a non-STEMI pattern, which includes an ST segment depression or T-wave inversion or night altitude, in this case, the acute lesion on coronary arteries is much less common, and many will argue that it's not the case to perform immediately an acute coronary angiography. Actually, reasons for delaying coronary angiography in these patients may include an early initiation of TTM, on hemodynamic optimization, or even neuroprognostication. And these questions were addressed by the recent COACT trial, which included more than 500 patients with out-of-hospital cardiac arrest from VF who were comatose, had no circulatory shock, had a non-STEMI ECG. And these patients were randomized to an immediate coronary angiography or a delayed coronary angiography. That is, a coronary angiography was performed only after neurological recovery. And the study showed that the outcome for these patients in terms of 90-day mortality was the same. Other trials are addressing this question and will provide answer to the question in the next few years, probably. In the meantime, it makes sense to schedule these patients for reperfusion strategies based on a series of other considerations and variables on a case-by-case basis. But it's not only about cardiac ischemia. Another important component of reduced cardiac output after cardiac arrest is post-resuscitation myocardial dysfunction, or PRMD. PRMD is nothing else than a diffuse myocardial staining that it may occur in absence of acute coronary occlusion, even with perfectly preserved coronary flow. And the causes include low coronary flow during cardiac arrest, ischemia or perfusion injury to the myocardium after cardiac arrest, or the depressing action of electrical shocks of epinephrine administered during cardiac arrest. PRMD presents itself as a shock needing vasoactive drugs, elevated cardiac enzymes, and left ventricular dysfunction, of course, both systolic or diastolic, that has been evaluated in several observational studies using post-arrest echocardiography. This one, for instance, included around 130 patients with cardiac arrest from non-cardiac causes, and despite the cause was non-cardiac, post-resuscitation myocardial dysfunction appeared in 1/3 of these patients. And as you can see in the graph, these changes included global hyperkinesias, regional wall motion abnormalities, or even a Takotsubo syndrome. As you can see in the graph, most of these changes were reversible early after cardiac arrest, but they were associated with an important hemodynamic instability. The prognostic significance of this hemodynamic instability has been assessed by another study, which included 162 adults with a shock following non-traumatic out-of-hospital cardiac arrest, in which the investigators evaluated patients on the first day after ROSC using echocardiography. They classified patients based on their left ventricular ejection fraction. About half of the patients had a normal or slightly reduced left ventricular ejection fraction. In the remaining half, the left ventricular ejection fraction was significantly reduced. And the results of the study showed, quite surprisingly, that after correction for major confounders, patients with lower left ventricular ejection fraction had a better outcome, both in terms of survival and in terms of good neurological outcome, which parallels old evidence from studies in septic shock showing the same result. But the parallels with septic shock does not stop here. The second important component of post-cardiac arrest cardiovascular dysfunction involves peripheral cardiovascular system with a distributive shock, with reduced vascular tone and impaired microcirculation, which configures a sepsis-like syndrome. Actually, as has long been known, that cardiac arrest is followed in the very first days after ROSC by a massive release of cytokines, especially interleukin-6, whose levels are higher in non-survivors. And the levels of interleukin-6 are directly correlated with the severity of organ dysfunction, as measured by the SOFA score, and interleukin-6 levels were the best independent predictor of severity of post-cardiac arrest syndrome in the study. But it's not only about cytokines. Endotoxin is also very high after cardiac arrest in many patients. Note that this is a logarithmic scale. And the highest levels of endotoxin, the lowest are the survival probability of patients resulting from cardiac arrest. A major source of cytokines and endotoxins is probably the gut. These are the results of a study from David Grimaldi and others published a few years ago that show that early after cardiac arrest there is a significant release of intestinal fatty acid binding protein, which is a marker of intestinal injury. But splanchnic organs may be both a motor of this response and the victims of that. This is the case for kidney. Acute kidney injury occurs in around 50% of patients after cardiac arrest with various degrees of severity, and especially in patients with post-ROSC shock, in which the risk of acute kidney injury is almost twice than those who don't have shock. And unfortunately, the acute kidney injury is associated with increased hospital mortality in this univariate analysis, and these data have been confirmed recently by this large and very recent observational study with multivariate analysis. Another target organ is the liver. Hypoxic hepatitis has been defined by the 20-fold increase of alanine aminotransferase during the first 3 days after out-of-hospital cardiac arrest. And although this may seem high, this has been observed in more than 11% of patients in that study. And the increase of ALT and other enzymes is very evident in this graph, and the same applies to coagulation abnormalities. This is the PT ratio here. And although this increase may seem very transient, that was associated to an increased risk of poor outcome. Indeed, in that study, hypoxic hepatitis was the major predictor of ICU mortality, and that was confirmed even after correction for post-cardiac arrest shock. So to conclude, death on day 3 in the first 3 days after cardiac arrest is extracerebral, maybe due to cardiac failure or circulatory failure, After cardiac arrest, there is a massive release of inflammatory mediators and endotoxin, and splanchnic hypoperfusion may have a role in this. And third, kidney and liver insufficiencies are common. They are generally transient. They are mainly a marker of ischemia perfusion injury, but they may contribute to overall mortality. Thank you for your attention.